Hi, I'm Dr. Brian Koffman, a retired family doctor and a CLL patient myself. I'm the co-founder, executive vice president, and chief medical officer at the CLL Society. Dr. Burke?
And hi, I'm John Burke of Rocky Mountain Cancer Centers in Denver, Colorado. I am a specialist in hematological malignancies, including CLL and lymphoma.
And Dr. Burke, you've been very much involved in a number of research projects. And even though your practice is more community-based, it does have that sort of academic flair of doing a lot of research. And one of the questions, we have some great drugs in CLL, but the question is, how do we use them? Do we use them in combination? Do we use them sequentially? Is there a way to limit the amount of therapy people are getting? And you're talking about what we call a trial in progress discussion. You had a paper that was published in Blood in a supplement there. Can you describe to us this, what I think it's called the BRAVE trial, what that's about, and why patients might be interested in this trial?
Sure. Thanks, Brian. The BRAVE trial involves what we're doing is we're taking patients who have been on therapy for their CLL with a BTK inhibitor, Bruton tyrosine kinase inhibitor, for at least 6 months. And there are three of those BTK inhibitors on the market: ibrutinib, acalabrutinib, and zanubrutinib. So anybody who's been on one of those drugs for a minimum of 3 months for their as initial therapy for their CLL then adds Venetoclax, which is an oral drug with a different mechanism of action called BCL2 inhibition, and adds Venetoclax for 1 year. So they take a combination of two pills, the preceding BTK inhibitor that they've been on, and then we add the Venetoclax for 1 year, and we treat with both drugs combined for a year. Then at the end of the year, patients stop their therapy, and we measure how deep their remission is after that 1 year, and then we're going to be monitoring them after the end of their therapy. And so that's how the trial is designed as a treatment for CLL.
So a couple questions I have about that. Just first, some logistic questions. Venetoclax is a very potent drug, and it needs to be started slowly. So having patients take the BTK inhibitors first would, what we use the term, debulk the disease, make the disease less risky. Is that part of the design, and is there still the ramp up necessary with the Venetoclax in the way you're doing the trial?
Yes, the Venetoclax, as you say, is classically ramped up over a 5-week period, starting with a low dose of 20 milligrams and ending with the final full dose of 400 milligrams daily. Just as way of background for those watching this, that's done as a safety measure in order to prevent or minimize the risk of what we call tumor lysis syndrome. What happens is if you take a patient with a lot of CLL cancer cells in their body and you give them the full 400 milligram dose of venetoclax from the start, you actually get so much death of those many CLL cells in the body that those cells release their contents into the blood. Those contents include potassium, phosphorus, and uric acid. And that process can create an unsafe environment for patients where you get this surge of potassium, phosphorus, and uric acid that can lead to damage to the kidneys and the heart. So we want to avoid tumor lysis syndrome. And in order to avoid killing all those CLL cells so quickly, that's why we do this ramp up, where we start a very low dose and we gradually escalate. What's nice about this trial is that we think the risk of tumor lysis syndrome is going to be extremely low for virtually all patients because their disease has been, as you use the term, debulked, right? So they've been treated with the BTK inhibitor for a minimum of 6 months. So pretty much everyone who's going on this trial has very little in the way of disease burden of their CLL, and therefore they should be at low risk of developing tumor lysis syndrome when this venetoclax is started. That said, we don't try to go faster than usual or anything like that with the venetoclax. We are just giving the standard 5-week ramp up on the venetoclax.
So once the patient starts on this, whether they've been on the BTK inhibitor for 6 months or 12 months or whatever, there's another month, there's another 12 months that are added on. Is that correct?
Correct. Yeah. So whether they've been on it for 6 months or 3 years, they still get the 1 year of venetoclax added on.
And does everybody stop at the end of the year, or do you use undetectable measurable disease or UMRD as a guiding point for that?
Everyone stops at the end of the year. We are not using the MRD as a guide to continue therapy for a longer period of time. So we're just giving the treatment for a year, then measuring the undetectable MRD rate. But then patients can stay off the drug, and we're following them after the end of that therapy.
And there's been a lot of interest in these all oral combinations, and we hope to see one approved later this year, acalabrutinib and venetoclax. And in the rest of the world, ibrutinib and venetoclax has been approved for many, or at least a few years in many Western countries. And there's new combinations coming down the line in early trials that look very promising. What's appealing about this approach rather than just from day one using both medications, and why would this be an appealing trial for a patient of yours with CLL?
Yeah, I think there's a couple things. I'll highlight really two of them that may be appealing to patients. First of all, is that we realize that many patients are out there in the world who already are on a BTK inhibitor. And, as you know, when we start patients on BTK inhibitors, the current standard is to keep them on that BTK inhibitor until either they have progression of their CLL gets worse, or they develop some toxicities that make it problematic for them to stay on the BTK inhibitor. There are many people out there like that who've sort of embarked on this course for their CLL. But we also realize that while they're on BTK inhibitor therapy, patients do develop side effects, and sometimes they are trying to tough it out and stay on the drug in order to treat their CLL, but they're tolerating some side effects to various degrees, some more severe than others. And so we realize that as patients are being treated with BTK inhibitors, some of them kind of are not so excited about this plan of staying on the drug for a long period of time. Maybe they've developed hypertension and they're now requiring a couple of medicines to control their blood pressure, for example. Or maybe they have chronic diarrhea and they uh, uh, don't like the experience of that. Or maybe the drug is just expensive and it's starting to weigh on their finances. So these are all reasons why a patient who may want to get off of BTK inhibitor, and this strategy where you take somebody who's been on a BTK inhibitor, adding the venetoclax, driving the disease burden down low, low, low to try to achieve this undetectable MRD state, in theory, should allow the patients to come off of all therapy after just 1 year of investment in the two drugs together, and then have a nice, interval where they don't have to be on drug therapy. So that's one scenario that's just a real world scenario that comes up all the time, and this study will help inform all of us as to what is the efficacy of driving this disease burden down to allow patients a treatment holiday for hopefully many years. The second, potential advantage of this strategy over just starting both drugs together from the beginning is what we were mentioning before with that little extra debulking of disease. So, for example, if somebody comes into me with a lot of disease burden of their CLL and we start them on acalabrutinib, and let's say we do that for 2 months, and then we introduce the venetoclax at that point, they could still have a pretty good disease burden after the 2 months of their BTK inhibitor, the acalabrutinib. And when I start that venetoclax, they may be still at say moderate risk of developing tumor lysis syndrome, and you have to be sort of careful. So another potential advantage of this slightly longer introductory phase with the BTK inhibitor is to debulk the disease a little bit further, a little bit more slowly, and then add the venetoclax a little bit later as a way to just reduce the risk once that venetoclax is started of tumor lysis syndrome. So that's another sort of theoretical potential advantage of doing it this way as opposed to say the way it was done in Amplify, where the venetoclax is added after a shorter term of BTK inhibitor.
And if patients are interested in this trial, this is a multi-center trial, how would they find out about it?
It's a multi-center trial. You can read about it on clinicaltrials.gov. It's called the BRAVE, BRAVE trial. And yeah, it's going on in many places around the United States.
And is it, if you're taking the BTK inhibitor, ibrutinib, acalabrutinib, or zanubrutinib,
Mhm.
or what about pirtobrutinib? Would that qualify the non-covalent?
Pirtobrutinib would not qualify. That's a drug that is not really being used in the front line. So this is patients who are on frontline therapy with BTK inhibitors. So pirtobrutinib for relapse disease would not qualify for this.
So this is only frontline. All right,
Correct.
any final thoughts on this or anything that you want to let patients know about this combination, this trial, or just generally about CLL?
Yeah, my only comment, we don't have a lot of time left, but it's expected that the trial may have completed enrollment within a few months. So if there are people out there who are interested, you do kind of want to not stall for too long because there probably won't be a opportunity to do this trial later in the year or next year. So, but other than that, we're excited about it. We do foresee, as you said, the possible approval of combination BTK inhibitor plus venetoclax in the US, and this is a variation on that theme. So it's a promising way to treat CLL.
And we'll put up a link to the trial on the website and a link to the abstract about it. And thank you very much, Dr. Barr. I think this is a very exciting trial. I really like the approach. And I think if it's appropriate for the patients, you should talk it over with their physicians and see if it makes for sense for them to enroll. Thanks very much for your time and all you're doing for CLL patients.
Thanks for having me.